I think this theranostic concept is going to be something that spreads across the country, and patients will be getting infusions in the same place where they get their PET scans. Nuclear medicine physicians will be joining all the multidisciplinary teams across all the different cancers. My name is Andrew Hendifar. I'm a medical oncologist. I work at Cedars-Sinai Medical Center, where I hold the positions of Medical Director of Pancreas Cancer, as well as the leader of the Gastrointestinal Disease Research Group. Neuroendocrine tumors are rare tumors. They're derived from the enterochromaffin cells. These are endocrine cells that occur in different places throughout the body. Many of these places are in the GI gastrointestinal tract. When these enterochromaffin cells grow and form tumors, many of them characteristically produce hormones. And when they do that, you'll get something that you might have heard called carcinoid syndrome. Some of these pancreatic tumors can produce hormones that will cause things such as an insulinoma or a VIPoma or a gastrinoma or a glucagonoma. Traditionally, there were very few treatment options for neuroendocrine tumors. The mainstay of treatment was surgical resection, and surgery was very important, and still is, but it was incredibly important in the past to remove as much of the tumor as possible. And the other therapy that we'd used in the past are somatostatin analogs. Those are injections of treatments that helps block certain receptors on the tumor to reduce their ability to produce hormones and also to stem their growth. I think the future of neuroendocrine tumor care is very exciting. Right now, we have dozens of approved therapies, from medical therapies including everolimus and Sutent, somatostatin analogs, supportive care treatments like Zermelo. We have radionuclide radiotherapy, which is approved, Lutathera. We have several new types of radionuclide therapies in development. And we also have several approaches that have been well established and currently continue to be practiced, such as cytoreductive surgeries and liver-directed therapies. I think the future of care is going to be, what is the best combination of these therapies for patients in particular scenarios? And the reason why it's been so difficult to come up with consensus is because we have a rare disease. One particular approach to treatment that's novel in neuroendocrine tumor is a concept called Theranostics. This is when you have a therapy and a diagnostic together. The prototype is what we think of as Actria scans. Neuroendocrine tumors are defined by the somatostatin receptors that dot the surface of the tumor cell. We have antibodies that combine this receptor quite effectively, and we can use that for imaging. And then we have imaging tests such as gallium-68, which is an amazing tool to be able to identify neuroendocrine tumors wherever they lie in your body. Well, technology as such now allows us, to those diagnostic antibodies, we can add radionuclide particles. The first one that has gotten approved, and I was fortunate to be a part of that study, the NETTER-1 trial, is Lutathera, which is lutetium combined to a somatostatin receptor agonist. So right now in development are dozens of compounds that are tweaking the radionuclide particle and the binding one. And what's really exciting about Theranostics is, of course, I get to invite someone new to our tumor board. So for decades, nuclear medicine physicians were involved in administering PET scans and helping to understand different diagnostic tests. Now, at Cedars and at places across the world, they now are delivering therapy. And they're very excited about it. I know Dr. Thompson at our institution is very excited to be treating patients with these therapies that are now being developed. We were lucky that this field started in neuroendocrine tumors, so as a neuroendocrine tumor provider and my patients were really excited to be able to be involved in that. We're seeing this type of approach being used in prostate cancer, and this is a very common cancer, and it's going to start moving to other malignancies where we're able again to target those malignancies with an antibody. That antibody shows us a nice picture of where all the little areas that the cancer is, and then we're able to combine that with a radioactive particle and basically radio nuke the tumor. I think Theranostics is a concept that will touch almost all of our cancer patients. It's something that's going to be adopted very shortly to a health clinic near you.